Hey, while we're waiting for folks to join here at GM Insights, I just wanted to show you something brand spanking new and really exciting to me, and that is that you can get your continuing medical education credits, your CME credits from the School of Medicine via text message. So let me just show you a couple of slides for that because I think it's really kind of cool. So, and I'll go over this again at the end, but here's basically what you can do. You can send a text message to 833-705-1500, and you just send them your email address. And then it tells you either, hey, you're registered for getting credits from Emory University School of Medicine, or it says you need to register. And if you need to register, you just put on a click. And then it says, hey, your account was successfully updated, and now you can use text messaging services for your continuing medical education. And then the second thing that you do is you actually text that you attended session 18055, and it will to that same number, and it will send you back something that says, hey, you've got your credit. And then there's a way in which you can actually go to look up your credit. So really excited about that. Again, I'll say more about that at the end of our session today. And we're just going to let some more folks join the room right now. Thanks everybody for coming today. And Dr. Clevenger, do you have your slides that you want to share from your end?
I do. That's all right.
Yeah.
I'm changing seats in the room.
Why don't you go ahead and let the go ahead and share that first slide then, please.
Okay.
Thanks everybody for joining Georgia MemoryNet Insights today. We're really glad to have Dr. Carolyn Clevenger here with us today. And so a couple of thoughts about Dr. Clevenger. First of all, she's awesome. She's my boss, and she is the director of the Integrated Memory Care Clinic and the Integrated Memory Care Community. She is a nationally recognized thought leader in ongoing care of persons living with dementia, and her integrated memory care model is something that Forbes called the best of the best of the models for care for persons living with dementia. And so she's got a lot of practical information for us today, and so very excited to have her go ahead and do that. Hey, Carolyn, thanks so much. Appreciate your joining today, and I'll give you the slides to share, and we'll get started. Thanks.
Always glad to be with you all. Thanks for having me. So today we're going to talk about agitation in dementia, which is, as you'll hear, so I'm just going to go ahead and tell you what I'm going to tell you. One of the most common symptoms of dementia, even though we use the word memory in all of our titles, like Georgia MemoryNet, Integrated Memory Care, agitation is where it's at. So a quick comment around just following up on Dr. Johnson's comments about accreditation and continuing medical education, and you saw the text instructions for that, and I will also show those to you at the end of this presentation if you forget the number. Quick disclosure statement in accordance with those compliance rules around continuing medical education. I have two relationships to disclose with companies that support some of this work, Otska being one of them, and Lilly as a member of their advisory boards. We'll not be talking about either one of the products that those organizations distribute, though. So agitation, as I mentioned, is, I think this is probably one of the best examples and uses of a word cloud I've seen, because this not only describes, word clouds have like the most frequently used words are the largest ones. If you've ever used that tool in your teaching or if you've been part of a conference, this also shows the chaotic nature of how agitation can feel, both to the person who might be experiencing and expressing these symptoms and the people around them. So it's described as increased, not necessarily directed in any particular way, just physical motor movement. People are restless. Sometimes they're aggressive, not always, and many times emotional distress accompanies that behavior that we're observing. So it's everything from non-aggressive behaviors like pacing, rummaging is sort of what I think about, the general sense of restlessness. It may also be verbal aggression. It may also be physical aggression, but all of that would be under the umbrella defined now by the International Psychogeriatric Association, or the IPA, who formed a work group of subject matter experts and actually came up with a clinical definition of this word that, if you've been in geriatrics for much time, have probably heard thrown around quite a bit by mostly our frontline clinical staff. And then I think if they've had enough exposure to us as clinical staff, then by family members as well. This particular document, I'll just point out, comes from the Gerontological Society of America, or GSA. They have actually an entire sort of description of both what agitation is and common causes and responses that you might consider. I think it's a very well put together document, and I will give kudos to my colleague Laura Matters, who was part of that writing group. So Ted told me that at Georgia MemoryNet and GM Insights, I had to add a patient case. And so I was like, oh, okay, let me think about a patient case. Like literally my patient at 1 o'clock today, which by the way, the reason you see much less of me is because I moved my clinic to Wednesdays. And so it's been harder for me to attend these. So my new patient is the case we're going to present, and like literally today, that's the guy. So this particular gentleman is a very classic. That's why I thought he was going to be a great case example for you all, because his symptoms are really what brought him to IMC, right? So IMC is this unique practice, right? It's primary care and dementia specialty care and caregiver services all under one practice. And so it's not that every single person in like our health system here who has dementia has to come to IMC, but we certainly do specialize in certain things. And the thing that prompts people to come to our doors, the thing that prompts referrals, the thing that prompts diagnostic evaluations, which is why so many people are diagnosed at moderate stage of their dementia, is these agitation symptoms, whether or not we see them that way. Now, this particular patient has been fortunate to have a really excellent primary care provider, and I'm very fortunate because I get to receive the referral from this person. So this is the documentation in their last visit note. So he describes this patient's behavior has been more erratic, increased repetitive actions. And then we have some great examples here, right? The patient took 9 showers in 1 day. He thought like it was morning time and sort of had some time or disorientation. And so continued to shower, which, you know, if you've done much dementia work, usually the complaint is people don't want to shower ever. So 9 showers sounds like not the worst. Repeatedly filling a water bottle, even if it's already full. So we have some sort of non-directed movements. They talk a lot about how his cognition and his memory have significantly declined over previous months. He was found walking along the highway. When the family redirects or sort of talks him down or away from these different activities, he's not aggressive, or belligerent was the word used. So easily redirected, but they definitely see this as something has changed. I also have referred to this in previous webinars as you know, when somebody has been, what I will say, pleasantly forgetful, right? We think about memory. Oh, they just need reminders and nudges and supports. We have these new sort of behavioral symptoms. You know, what worked for us before isn't working now, which is probably why we're making a change in their provider team or the practice, really. It's certainly not about the provider, because she had a great provider before, but now we've got a whole team of folks. So back to this definition. You know, in this particular case, the note did not come across to say like this patient's agitated. But it's something that a lot of times we get, especially if you are covering residential care, so assisted living, memory care units, personal care homes, or skilled. You would get this sort of message: this patient is agitated. And, you know, for 20 years now, I would talk to nurse practitioner students, and I would say, when somebody uses that word agitated, it was like so irritating. I'm like, paint me a picture. Describe to me exactly what it is you mean when you use that word agitated, because it can mean all sorts of things. And so very grateful for the work of this work group and the IPA that really put together a structured clinical definition for those of us who are getting those sorts of reports. So the first criterion for someone to have agitation in dementia is that they have to have an underlying dementia, right? So whether that's Alzheimer's disease, frontotemporal, Lewy body, vascular, and so forth. Or they can even have, you know, MCI or another sort of cognitive disorder that might be considered pre-dementia. But I've been hearing mostly agitation and Alzheimer's disease, agitation and Alzheimer's disease. This agitation definition is on any dementia syndrome, regardless of underlying pathology. The next criteria is that this person exhibits these more specific behaviors, and they are associated with either observed or if inferred evidence of some emotional distress. And you'll hear in just a few minutes some examples of how this comes out, what we learned in some further work that we did around this with family caregivers, as opposed to or differentiated from clinical staff in terms of the way we observe and interpret behaviors related to those emotions. It can't be something that just happens once or twice. It has to be either persistent or frequently recurring, minimum of 2 weeks. And here are your three overall categories. So pay attention to this. This is the excess motor activity, like our friend, my new patient, was exhibiting, right? So he's sort of doing, I would say some of those are sort of restless. I will tell you one of the hardest things. I know a couple of colleagues who were on this work group, and then I did work that built on this work group. The list of examples was probably the most lively discussion because it can take so many, like who was going to say fills a water bottle with, like, regardless of it being filled, or takes 9 showers in a day. Verbal aggression, I think it's a little bit more clear, right? So we certainly know verbal aggression has been a challenging thing. There was at least one study, and I believe it was in a veteran population, that was verbal aggression specifically that was the most likely contributor influence on placement in an institutional setting by family caregivers. So this might be loud verbal aggression. It might just be mean. So profanity, but it tends to feel like this person is sort of escalating in terms of their verbal communication. And then there's the physical aggression, which certainly gets people, the covering provider, a call, right? So this is potentially endangering people around them, often care team members, and certainly makes them at risk of not being able to participate in their care, which, by the way, is one of the next criterion. So that these behaviors are severe enough, they produce enough disability that there's impairment in the interpersonal relationship. So maybe that's the family caregiver, spouse, adult, child, or otherwise, that it impairs their ability to have social functioning. So now they're not able to go to group activities. They're not able to go to whatever type of engagement or cognitive stimulation things that might be happening. And it impairs their ability to perform or at least participate in bathing, feeding, toileting, dressing. And then the last criterion is that it's not so attributed solely to another psychiatric disorder. Certainly, people can coexist in a bipolar disorder and a dementia syndrome, but these behaviors are schizophrenia and dementia. But this is not solely just due to that underlying psychiatric condition. So that is our official definition. Now, when families come to you, they're probably not saying, well, they're having excess motor activity. So they're going to describe to you, though, the behaviors. And for me, as the receiving clinician, it's really helpful to actually have those specific behaviors outlined in that history of present illness, right? Like, what exactly is it that they're seeing? But families, what we found, so as part of a work group that did some listening and focus groups, so some social listening and then some focus groups. And we were looking at these two groups of frontline staff and family caregivers. And when family caregivers are talking about agitation, they are not just saying like they're doing these things, they're interpreting it. They're doing it because they're mad at me. They're doing it because they're frustrated that the door is locked. They're doing it because I feel like they must be anxious, right? They are interpreting that for a variety of reasons, including they have a longer relationship with this person over time, and maybe they've seen something related to the way they used to be or part of their personality. And in that case, because again, maybe this is part of their personality, they don't want to bring those up to you as the clinician until something has become more serious or more persistent and they're not feeling like they're able to do much about it. So many times, even though the order of those symptoms, by the way, are in order for a reason, right? Motor activity, but pretty easily directed. Verbal aggression, that's a little bit harmful. Some caregivers might get their feelings hurt, but mostly people are okay. Physical aggression, now we're really worried about their ability to get care. It's that last stage when things have escalated now and things have been maybe boiling up to this point, and that's when you're going to find out about it, which makes it challenging to treat, of course. Now, if you're hearing from frontline staff, if you're covering residential care, as I mentioned, this person is coming to you or you're getting these calls because they are disruptive, right? They are not able to participate in group activities when we need people to participate in group activities. They're not able to have their ADLs or their bathing or their dressing or their toileting done in a timely way so that we can be efficient with other people that we're caring for on the same unit. They may be violent, so we're concerned about caregiver physical well-being, paid caregiver, and other people on the unit. And in my experience, the word agitated has typically come more from frontline staff than others. And the problem that I've always had is it's just sort of a catch-all term. Every behavioral symptom seems to come to agitated. And then it's up to you really as the clinician to tease out what we really mean by that. So here's some examples of things you can ask to family care partners. So in my practice today, that's mostly who I'm going to be talking to, our family care partners, not paid or professional clinicians. And so it's really helpful in the course of every visit, if this person has this dementia diagnosis, that we're specifically asking because, as I mentioned, they're much less likely to bring this forward to you until it's serious. So the way they behave or relate to you, have they lost their filter? Do you think that they're quick to anger? And then we're kind of doing our usual old cart. So, when did it start and what's been going on? And anything make it worse? Does anything make it better? All those sorts of things. And then timing, of course, we know is very helpful because when people are more tired, their threshold is lower for those types of symptoms. It's important to recognize agitation when it exists because it also does influence your coding. So if you've not caught up with this, this is a change in October of 22, I believe. So it's a good, year plus at this point. But where you saw the change in the diagnostic coding from, mild cognitive impairment or dementia over here, and then you have sort of the underlying cause, you have the stage, and then these last characters are about behavioral and psychological changes. And so I can go through a number of reasons that that's of value to you to include those final details, including just the most basic. If you are about to come up with a treatment plan, whether that's non-drug or drug related, you should have a rationale and a reason that we're prescribing. And we do now have some things with indication for agitation specifically. So the rub, of course, if you've ever heard me talk about this before, I just can't help myself. I have to say, people don't have just one of these extensions, right? People have psychosis and agitation potentially. So the question though is then what do we do about this, and why is it so high priority for treatment? And that I may be preaching to the choir here, but again, I'm going to go ahead and not bury the lead and tell you what I'm about to tell you. So remember, this is the leading cause of institutional placement, verbal aggression alone. It's a leading cause of caregiver burnout, and that is both paid and professional. So not to mention there is a source of distress for the person experiencing it potentially. So there are a number of recommendations for then how you treat it and how you begin. So there are a couple of ways to approach this. One is sort of tailoring to the person's abilities, preferences, and that particular day and context. So for someone who, for example, is having sort of this undirected movement and restlessness, can we direct it towards something that is more purposeful and beneficial? So can we do a walk with accompanied by someone? And so we've got some supervision, and maybe someone to also point out the fact that the dogwoods are budding and the azaleas are out. And so that goes along with this next piece where the psychosocial interventions and interactions go a long way. For people who are not mobile, for people who are really experiencing a lot of distress, again, you weigh this with the individual approach, but whether or not something like therapeutic gentle touch may be helpful. There's a lot around the environmental modification, and that includes the people around folks. So unfortunately, fortunately, the person who is experiencing these symptoms, the person living with dementia, is not going to be able to modify their behavior alone. The only person who can modify behavior are the people around them and how they're responding to them and how they are stimulating them. And so a number of these items relate to sort of those activities, the touch, the approach, the how we're speaking to them, and then focusing on what are the internal stimuli potentially that would be affecting mental and physical health. So again, untreated pain. I think a number of clinicians in the geriatric space would say, scheduled Tylenol goes a long way to reduce agitation. So Tylenol is not indicated on the PI for agitation and dementia necessarily, but if that's what's underlying cause, or someone's having poor sleep due to other medical conditions, due to the environment, due to something else, certainly our threshold is low for then having some of these disruptive or agitation behaviors. And then considering what we're doing in terms of stimulation. So the amount of caffeine and the timing of caffeine, just overall, like the way we are nourishing our bodies and what we are giving to this person disrupts hormones in a variety of ways. And so considering what's in that, I think there's just one note here, what's not recommended, which is alcohol, cannabis use, I think, which we associate with sort of this person seems high strung. They seem really like restless and agitated. So let's sort of lower things down a little bit with alcohol or with cannabis. And both of those have not necessarily great effectiveness given what's happening in the brain that's driving agitation, and also, of course, come with other problems and adverse effects in a few hours potentially. So then how do we alter the environment? This is another sort of the physical environment. So if you've not been familiar, but if you've probably seen the Snozellen rooms, right? The whole concept is everything in the environment is addressing a sense in a soothing way. So whether that is music, whether that is smell, whether it is the actual touch and the fabrics and what is on our bodies, like I'm about to go to the north tonight and I have sweaters packed, and I for sure was not packing the itchy ones, right? So all of those sorts of things. Um, Animal assisted therapy certainly can be a helpful component in the environment. And I know I've had situations where this has to be a animal that they find soothing, and so if not, then that can actually be dangerous for the animal. Uh, Also, though, consider robotic pets. I'm a big fan of like the robotic cats. I was just talking with a geriatric resource nurse actually from a niche unit yesterday. She was talking about their success with robot pets in the hospital setting on their ACE unit. And so, a big believer in those as well as therapeutic dolls. I probably got the most texts and emails the day I presented some of this content in a really rapid format on primary care huddle a few weeks ago about this weighted blanket option. So I don't have a preference. I don't have a specific weight. I will just tell you probably the best $20 you will spend on Amazon for someone who just needs some soothing with that object. So again, we're really aiming for that soothing environment. We're aiming for optimal levels of stimulation. So we reduce the noise if it's overly noisy. We increase maybe a little bit of noise if it's too silent. We think about distractions, and sometimes that's a snack, sometimes it's an object, sometimes it's directing into an activity. Um, Sleep hygiene or quiet time. Quiet time sounds more fun than sleep hygiene. But just sort of thinking about the way that we would want, especially in late afternoon, to have an environment around us that is soothing and not overwhelming. Of course, if people are coming to you as the provider or prescriber, they're usually looking to talk about medications. And so I think it's just important for us to think about prescribing principles as opposed to, oh, it's agitation, then you give it this, right? It's not like it's gram negative rod, it gets this antibiotic, right? So it's a lot more fine tuning and investigative work that you'll need to do, first of all, to understand what might be underlying some of these symptoms. And are we really dealing with agitation, or are we having some other type of internal stimuli like a fixed or a really vivid hallucination or delusions that are driving then some of the outward behaviors that we're seeing? So that's sort of the first component, is really understanding that it is agitation that we're dealing with. Agitation itself does have some better biological understanding of the neurobiology of what's happening. And so here are the things that you sort of consider that this is a disruption in the SND. So that is serotonin, norepinephrine, and dopamine levels and locations and activities in the brain. And so if you've seen medications that target one or all of these neurotransmitters, that would be perfectly appropriate to do that. Whether it does that as specifically as we want is a different question. But so in agitation, we have lower serotonin. So you may see some benefit with something that inhibits the reuptake of serotonin. Dopamine, on the other hand, is increased in this situation. And so dopamine, which we normally think of as our joy chemical, it sort of drives a lot of it's excitation, certainly. But in this case, it does seem to increase the fear responses that are conditioned fear responses. So this is probably this person has some experience with, some exposure to, or some personal experience behaving and responding to things, fearful situations in this way, and they're repeating that behavior, which, by the way, helps you sort of understand why a family member would interpret things the way they interpret, right? So this may be a fear response they've seen this person exhibit before, and so they're interpreting it in that same way. The thing about the norepinephrine is not so much about like high or low, it really is where it is most active. And so it really is from that prefrontal cortex, which is where you make all your good decisions, your socially acceptable decisions, your working memory sort of holds there. And it shifts then to the subcortical and posterior cortical regions. That's really more of your deep brain, where a lot of your emotions are like firing. The prefrontal cortex should be helping to regulate those emotions. So you don't have the typical like chemical reactions in the part of the brain to regulate, and we're really firing up the most excitable and emotional parts of the brain. So it makes sense that this person would begin to escalate, and to be around them probably makes people around them feel kind of like on edge or overly excited. And I don't mean that like in the good way, right? So really hard to negotiate situations where maybe this person could have let things like, sort of roll off their back before. They didn't have much, I would call it, this makes me think of that progressively lowered stress threshold and the neurobiology of why that would be. So in terms of if you are the prescriber and provider, some things that you can consider that may be effective in these cases. So I understand why alcohol would be seen as a beneficial thing because it does typically flood the brain with GABA. Unfortunately, it disrupts other things, including factors that make it difficult to sleep and so forth after, or maintain sleep, I should say. GABA agonism, though, so something like a gabapentin may be helpful just to bring down the excitability of that amygdala. And so I think when you're doing maybe an oral medication, you have a bit more ability to sort of tailor and tweak the amount of medication that it requires to sort of bring just to me, that when I'm using GABA in these cases, I'm trying to take this person from a 10 to like a 4, right? So we're just trying to bring the situation down a bit. There is some evidence that beta blockers may be helpful in decreasing that norepi response. So again, we're dealing with older people. If a beta blocker makes sense overall, then it may be helpful. Doesn't make sense because we're already dealing with some hypotension, orthostasis, and so forth. And you have to consider that. Part of the reason that people have used antipsychotics for so long around agitation with mixed results, obviously, is that it may decrease that perception of threat. So you don't get as much of the conditioned fear response. Obviously, it comes with a whole host of other adverse effects, which I should say all of these options are going to come with a both benefit and risk. The value of then our newer atypical antipsychotics is that you get a little bit more of a specific and targeted reaction from the medication, right? So if you flood the brain with GABA, you flood the brain with GABA. It's not necessarily just going to target the receptors just around the amygdala. So then you have the risk of sedation. People are off balance, they're dizzy, they fall. Ideally, with the newer atypicals and those that are actually indicated for agitation, you should see a more specific reaction in the receptors and the feedback systems we're trying to target in agitation. So in that serotonin, norepinephrine, dopamine feedback interaction, as opposed to getting this sort of blanket response for the brain. And so as you're thinking about prescribing, you want to keep in mind, of course, sort of lowest risk, right, that we can gradually titrate up, but you're considering specifically because we have, I think, just one medicine with indication for agitation. We're often working our way toward that medication because it also carries significant risk. And we're trying to do other things that maybe are helpful in other ways, right? So for example, the person who has maybe a bit of a tremor or some, low back pain or neuralgias, does it make more sense to have gabapentin increased to address agitation as opposed to going straight to something like all the way at the end, which I would say would be your brexpiprazole. So I have a minute for questions, but I'll leave the slide up here for the evaluation. And then as we're talking, I can also pop over to this text number again for CME.
Carolyn, thanks so much. I really appreciate that. I know that being in the call group for the Integrated Memory Care Program is such a different experience than any other call group that I've ever been in. And so one time I did get a Saturday call from a daughter caregiver who said, my husband just talks so loudly and repeats the same thing over and over again. And so thinking about and looking at your slides, I would have recommended some slightly different things. It was cold outside, but maybe a trip outside for exercise for the both of them, a change of environment would have been good. There was nothing that was particularly threatening about what he was doing. I suggested that maybe even some earplugs for her so that she could still hear him, but it wouldn't be so loud to her. I'm just thinking about that very brief scenario. What would you recommend to me or someone like me to do different? Just loud talking, on and on and on.
This is interesting. So this is like a weird case. I had a similar situation, believe it or not, as this guy, might have been the same patient. Anyway, but you sometimes get some benefit by redirecting the specific activity. So what I wonder is there music that he would like to sing along to? And so then, can we still sort of have that, like, whatever it is we're trying to sort of get out? I had one guy who would just it was loud, but he was also like disruptive. Like he would be like, hey, she'd like jump out of her skin every time he did it. I think the earplugs were probably the best thing. And the biggest challenge for them was like, there were certain environments that they could no longer go to as long as that was happening.
Right. Thanks for that. I think that the 45 minutes that I spent on the phone with her might have been therapeutic. It maybe was for me, hopefully for her and for him. But
Probably
yeah,
for-
these can be very challenging behaviors, which was what you
yeah.
led with. And so thanks so much for that. Questions of anybody who's on the call today, situations that you've run into, thoughts that you have about the presentation? You can give us some feedback about today's session or other sessions by scanning this QR code or that link that's there. Again, we put in some information about how to get your CME credit by text, and so follow that if you're in the text. Dr. Monica Parker, when do you refer these patients to psychiatry?
Yeah, so I think if you have, I mean, our experience is generally we sort of have our like first line approaches. It's not effective. We have second line approaches. And then, honestly, for us, this is just for myself, I'm comfortable dealing with SNRIs, SSRIs. I'm comfortable with, obviously with gabapentin. If this person is really looking like they're headed down the level of they're going to need something like an aripiprazole, brexpiprazole, that's not something I typically start. I generally would refer to my psychiatry colleagues to at least initiate and titrate that. And I'm glad to manage and monitor from there.
Great, thanks for that question.
Thanks for the question.
Anyone else with a quick question? Hey, we really appreciate your joining us today on GM Insights. Thanks for the 34 people who joined. Great attendance, and look forward to seeing you later. Later on, you'll receive some information about where to find other videos that we've previously recorded. And so if there's a topic that you missed and wanted to watch that, we appreciate your checking that out. Hey, thanks so much. Have a great day, everybody. Thanks, Dr. Clevenger. Appreciate you.